Okay, welcome everybody. This is a short tutorial on head injuries. It's aimed at an introductory level, so aimed at SHOs who are just starting their first placements in the emergency department. And I hope it will help you with your initial decision making when you're seeing your first patients who are presenting with a head injury. The objectives of the tutorial are to look at the initial assessment of head injuries, what clinical features we should be looking for in our histories and examinations, looking at what the presenting clinical features of head injury might be, and then spending some time looking at the criteria by which we should decide whether to perform both CT head imaging and also further imaging of the cervical spine. I want to consider some special cases, namely the anticoagulated patient, the intoxicated patient, and the elderly patient. We're going to look at intracranial injury and its management. We'll look at some criteria we should use for discharging patients and discharge advice, and talk a little bit about some post-head injury symptoms. As with most presentations to the emergency department, the clinical assessment should start with a thorough history. We need to find out exactly what's happened to the patient and the circumstances that they've sustained their head injury. Any exacerbating factors, so whether they've been under the influence of drugs or alcohol, or they may have been assaulted. We need to also be able to decide whether they might be at increased risk of having an intracranial injury, for example, if they are on an anticoagulant medication. Head injuries quite often don't just occur in isolation, and so it's important that the patient's fully examined to look for evidence of other injuries. The head should be examined carefully, looking at the scalp for evidence of contusions or lacerations or swellings and hematoma formation. These should be clearly documented. Small scalp hematomas can be quite easy to miss unless you look carefully for them. It's also important to look for any evidence of base of skull fracture. And in a second, we'll just go through exactly what those features are. But you should look for them and record in the notes that you've looked for them and whether they're present or not. Any injury that occurs to a patient above the level of the clavicles should make you think carefully about whether that patient may have a cervical spine injury. And so assessment of the cervical spine is important. And again, in a second, we're going to look in a bit more detail about how we should perform that assessment and the criteria by which we should use to decide whether we need to perform any further imaging of the cervical spine. It's really important that patients presenting with head injury do have a full neurological exam, and a full neurological exam includes an examination of their mental state, their Glasgow Coma Score, and that Glasgow Coma Score should be recorded with the score broken down into the three components of the Glasgow Coma Score, so eyes, motor, and verbal. There should be an examination of the cranial nerves and also the peripheral nervous system, and that should be clearly documented in the notes. We see a lot of patients with head injury, and I don't think that you need to spend sort of a lot of time recording your neurological examination of over two pages of notes. I think that if the neurological exam is completely normal, then I think it's acceptable to document in the notes that cranial nerve exam normal, peripheral nervous system exam is normal. But if there's any abnormality, I think it's good practice to then expand your note keeping and explain in detail the abnormality that you have found. So what sort of clinical features are you like to see in head injury? Well, depressed conscious level is one of the most commonly seen presenting features with more serious head injury. Patients can sustain seizure activity, which can be shortly after receiving their head injury, or if there is intracranial pathology that's progressing after they've presented, they can seize, and we might witness that. Another common presentation that patients with head injury present with is confusion, which can also have features where they've sustained memory loss, which can be anterograde, so that they're failing to lay down new memories, and you can tell them something or give them a piece of information, but they just don't retain it, and then will ask the question again repeatedly, which can be a little bit frustrating for the patient and for those caring for them. But it can also be retrograde amnesia, which is amnesia where the patient doesn't remember what's happened to them for some time in the past prior to receiving their head injury, so they might not remember what's happened at any point during the day up to the point where they sustain their head injury. Patients can also be quite agitated after a head injury, and it can be a particular challenge when patients can be quite difficult to manage, quite difficult to assess and examine because they are cerebrally agitated, and it's very important to be aware that patients who are agitated can be difficult, so it's easy to be a little bit dismissive of them, but you have to be aware that they may be harbouring a serious head injury which underlies their agitated behaviour. Likewise, a significant number of patients that present to the emergency department with a head injury will be under the influence of either drugs or alcohol, and that can very much cloud the clinical picture that you get. And I would urge you to never assume that a patient's altered mental status, agitation or confusion is due to alcohol or the substance that they've taken. It may well be that it is being caused by alcohol or the drugs they've taken, but if you go in with the attitude that it's possibly due to their head injury, you're more likely to make safe decisions. Patients may well have a focal neurological deficit, and that can present in a wide number of ways, depending on where the lesion is. You may well see a focal neurological deficit where a patient, for example, might have unilateral weakness or sensory changes, but you may also see changes in the cranial nerve examination. For example, if a patient has a basal skull fracture that's damaged the facial nerve, they may present with a unilateral facial weakness. So it's important, in summary, that patients do get a thorough and full neurological exam. Sometimes the neurological deficits can be quite subtle to detect. Vomiting can occur in response to raised intracranial pressure, and in adults after a head injury it is significant if the vomiting is more than one episode and it's continuous and unrelenting, and is something that should be taken seriously. It's important to look out for basal skull fractures, not because the basal skull fracture in itself is a particularly harmful pathology, but it's just that if you've sustained a basal skull fracture, it makes the probability that you have also got an intracranial hemorrhage that requires neurosurgical treatment much more likely. So that's why it's so important that we do detect the basal skull fractures, and it also mandates CT imaging of the brain if you do detect a basal skull fracture. I'm sure you remember from medical school the signs of basal skull fracture are panderized, so periorbital bruising bilaterally. You can get panderized from other causes other than basal skull fracture, but if you see a patient with panderized, consider is it due to a basal skull fracture. You see hemotympanium or bleeding from one of the ears, which can occur in response to a basal skull fracture. Battle sign is mastoid bruising, so bruising behind the ear. And the other thing to look out for is cerebrospinal fluid leak, either from the nose or the ears. It can be difficult to tell when the CSF leak is from the nose, whether it's CSF or not. One subtle sign that you can sometimes see if you look out for it is something called tramlining, where when the CSF is mixed with blood, the blood separates down the periphery of the line of CSF, and it looks like a tram line, which doesn't occur with other fluids coming from the nose. The other sign you sometimes see is when the CSF leak soaks into a white sheet, you see a chromatography effect, whereby the blood and the CSF separates out, and that can also be a subtle sign that the fluid you're seeing is CSF. If you're unsure whether it's CSF or not, the safest thing to do is to assume that it is and investigate further. The other thing to look out for is unilateral pupil dilatation. It's not uncommon for patients to have one pupil that's slightly larger than the other, which has a number of underlying causes, such as Holmes AD pupil or being due to direct trauma to the eye. If a patient has unilateral pupil dilatation that's secondary to a head injury, we'll talk a bit more about the pathophysiology of that in a minute, but it's pretty unlikely that it's due to the head injury if the patient's fully alert and fully conscious. And as I say, we'll talk a little bit more about that in a second. Another clinical feature that you might see is a Cushing's response, which is the physiological response to raised intracranial pressure, where you see a hypertensive response as the body attempts to continue to perfuse the brain, and this is associated with a relative bradycardia. Cushing's response is quite a late sign to raised intracranial pressure, and if it's occurring, should alert you to the possibility of impending critical rises in cranial pressure. The other thing, just to make clear, is that it is entirely possible to have a serious intracranial bleed without initially there being many clinical signs to see, and it is possible to lull yourself into a false sense of security. It's known as a patient who is talking and dying. So the majority of head injury patients that we see will be fully alert and will not have an intracranial bleed. But it's just important to be aware, be careful with your clinical assessment, and be aware that your patient in front of you is fully alert and fully orientated and has a normal neurological exam, can still have a serious underlying intracranial bleed. So how do we decide when to perform a CT head scan? So the principal guidance that we rely on to give us the criteria for making this decision is the NICE head injury guidance. And this guidance has been available for several years now in this form, and at the BRI we do follow this guidance and use it to help us make our clinical decisions. It's important that you familiarise yourself with the algorithm that's shown on this slide, and make sure you go through it and you understand it. I'm sure most of you have seen it before. Following the algorithm down, this guidance just applies to adults, and you look for a list of initial risk factors which are listed in the third box down. Those being that if a patient has a Glasgow Coma score of less than 13 on initial assessment, or has a Glasgow Coma score of less than 15 at 2 hours after assessment, a patient has a suspected open or depressed skull fracture, or has any sign of basal skull fracture, has had a post-traumatic seizure, has a focal neurological deficit, or has had more than one episode of vomiting. If your patient has had any of those features, it's quite straightforward. Then you should request a CT head scan, and that scan should occur within 1 hour, and a report be available for that patient. If the answer to all those initial criteria is initially no, you just have to ask a few more questions. So, is the patient on warfarin? And if the answer to that is yes, the NICE guidance says that a patient should have a CT scan within 8 hours of head injury. We're going to talk a little bit more about anticoagulated patients in the next few slides. But this is what the NICE guidance says. If the answer to the warfarin question is no, then is there any loss of consciousness or amnesia since the head injury? If the answer to that is no, then no imaging is required. If the answer to that's yes, then are any of the following risk factors present? Is the patient over 65 years of age? Do they have a history of a bleeding or clotting disorder? Has the injury that's been sustained one that's judged to have a dangerous mechanism? So a pedestrian or a cyclist struck by a motor vehicle, an occupant who's been ejected from a motor vehicle, or a fall from a height of greater than 1 metre, or a fall down 5 stairs. And also the last feature being, has a patient had more than 30 minutes retrograde amnesia of events before the head injury? And if the answer to any of those features is yes, then the patient should have a CT scan within 8 hours of sustaining the head injury. Now, I mentioned before that any patient who sustains a head injury, we also need to consider carefully their cervical spine. And there are 3 pieces of guidance which are of good quality and are accepted for use in the emergency department. There is currently work on a departmental guideline which most closely fits with the Canadian C-spine guidance. The NICE head injury guidance also fits quite closely with the Canadian C-spine guidance, but I wanted just to make you aware of the NICE head injury cervical spine guidance, which is detailed on this slide. But and I don't want to go through this in detail now, but you should be aware of this guidance, and you should go through it and understand it. But the other 2 pieces of commonly used guidance with regard to when you should image the cervical spine are the nexus criteria, which is the easiest to remember and apply, but in my experience leads to more imaging of the cervical spine than when you use the Canadian C-spine rule. The nexus criteria have a set of 5 criteria, and if you can answer negative to all of them, then the patient doesn't need cervical spine imaging. So the first feature to think about is, has the patient got a focal neurological deficit? The next is, has the patient got any midline spinal tenderness? Do they have an altered level of consciousness? Are they intoxicated? And do they have a distracting injury? If you answer no to all of those, then they don't need a cervical spine. They don't need cervical spine imaging. I've put an internet link at the bottom of this slide for MD Calc, which has an online calculator for calculating this, but it also has the key references for anybody who wants to look at those. Nexus criteria has been around now for a long time, and it's perfectly acceptable to apply these criteria in the emergency department. The last set of guidance I wanted to make you aware of, and I think the most useful in clinical practice, is the Canadian C-spine rule. It's a useful guide, but it's slightly more complicated than the nexus criteria, and it can lead to clinicians being a little bit confused as to what what is meant by this rule. There's a summary of the guidance on this poster that's detailed on this slide. The first thing to consider with this Canadian C-spine rule is there any high-risk factor present which mandates radiography? So those high-risk factors are age over 65, a dangerous mechanism, which is detailed in that box down at the bottom on the right-hand side, or is there any paresthesia in the extremities? If the answer to any of those questions is yes, they need to have radiography. If the answer to all those things is no, then you need to ask yourself, are there any of these the low risk factors present? And it doesn't have to be all of them, it can just be one of them. If any one of those features, so a simple rear end motor vehicle collision, they're sitting in the ED, they've been ambulatory at any time since their injury, the onset of pain was delayed from the time of the injury, or they have absence of midline tenderness, any of those, if any of those are present, then you are then allowed to get the patient to actively rotate their neck. If they can rotate their neck to the left and right for 45 degrees, they don't need any radiography. If the answer to all of those features is no, then they need to have imaging of their cervical spine. In terms of radiography, what imaging modality do you request in terms of imaging their C-spine? Do you need to request plain films, or do you need to request a CT scan? So in my practice, if a patient's going to have a CT scan of their head and I want to image their cervical spine, then I would request a CT scan of their cervical spine as well. If they're not going to have a CT imaging of their head, and you think that the risk of them having a cervical spine injury is relatively low, then plain X-rays of the cervical spine should be requested. You should remember that whilst plain X-ray cervical spine imaging detects most big cervical spine injuries, it doesn't detect all of them, and it's not as sensitive as CT spine imaging, but it does provide imaging with a much lower dose of radiation to the patient. So it's important to think about which imaging modality you use, and I think it's something that's worth discussing with the senior doctor on the floor to decide exactly which imaging modality to use. I've put this slide in about discharge criteria quite early because I think it's one of the most important things, that the majority of patients that we see and assess with head injury will be discharged from the emergency department, and it's important just to consider a few things before you discharge your patient, and a couple of things to do that are really important. So all patients that are discharged after a head injury should be completely alert and neurologically intact, and they should be discharged with a responsible adult and should have somebody that's going to be at home with them for at least 24 hours after their head injury. We should be giving them verbal and written head injury advice, and there's written head injury advice leaflets available in the department, and we should always be discharging patients with those. It's also important to go through the features that we would want the patient to return to the department if they experience. So if a patient is persistently vomiting, if they have an episode of decreased conscious level, if they suffer a seizure, if they're developing any focal neurology, if they're developing a very severe headache, or if there's concern by the patient or their relatives, then they should be advised to return back to the emergency department. And as with other conditions, they should be given clear safety netting advice on what to do should they experience those features. I was involved recently with a coroner's case whereby a patient was seen in the emergency department and then discharged after a head injury, and they weren't given head injury advice. And whilst the coroner can accept the difficulties of head injury assessment, it reflects quite poorly on the medical care a patient receives if they don't get given good quality discharge advice. So please remember and make sure all patients do get given that advice to go home with. There are three special circumstance groups of patients which I just wanted to briefly talk about. The first group are elderly patients, which we quite often see they may have fallen, had a mechanical type of fallen and hit their heads, or they may have had a collapse episode. It can be quite easy to miss a significant head injury in this population because there are often other clinical features going on. But if you see an elderly patient who has collapsed or had a fall, then make sure you examine and look very carefully for evidence of a head injury. As patients get older, they because of the reduction in their brain volume, can be an increased risk of sustaining subdural type bleeds, and they can be quite slow bleeds which don't produce clear neurological signs at the time that they're initially seen in the emergency department, and then if they go home, these subdural bleeds can extend and lead to the patient coming to harm. So it's very important to consider when assessing your elderly patient, one, do they have a head injury, and just be very careful in considering whether they do need a CT scan. In my practice, I've got a lower threshold for CTing an elderly patient's head than a younger patient. Another difficult group are intoxicated patients. They're quite difficult to assess, and they're also quite difficult to decide whether their behaviour and the way that they're interacting is due to alcohol, or whether it's due to their head injury. As I said earlier, never assume that a patient's behaviour or their confusion is due to the alcohol. It's best to carefully consider whether it's due to the head injury. There are a number of strategies for their management. The first is to have a strategy whereby you CT their head early, because if the CT head scan is normal, then you can be a little bit more relaxed about what's going on with the patient. The other strategy is to observe the patient and give the alcohol time to wear off, and watch closely. And if there are any clear indications for CTing during that period. Both strategies, I think, have pros and cons, and both are acceptable as long as you carefully consider carefully consider what's best for your patient. What you shouldn't do is discharge an intoxicated, head-injured patient, because it's just very difficult to make that confident clinical decision that there's no significant head injury when all you've had is an intoxicated patient to assess. So it's entirely appropriate for intoxicated, head-injured patients to be cared for on the observation unit for a period of observation until they're sober and can have a more coherent and clear clinical assessment and neurological exam. The last group of special circumstance patients are anticoagulated patients, and by anticoagulated patients, these are patients that are on warfarin, but now it's important to be aware of the novel anticoagulant medications such as dabigatran and rivaroxaban. These patients are at increased risk of bleeding, and they're also at increased risk of relatively slow bleeding, and so we need to consider a strategy for imaging these patients. We've recently developed a guideline at the BRI which gives us guidance about when we should be imaging patients. You can see on this slide that there's an algorithm which essentially the anticoagulated patient initially should have the same triggers for having an initial CT of their head as any other patient. The difference comes in this group of patients that if they either don't need immediate imaging or their immediate imaging is normal, then we need to carefully consider whether they should have further imaging further down the line. And you can see on this algorithm that if the patient doesn't require immediate initial imaging, we think that a patient should have a CT head 4 hours after the injury, or sooner if it becomes clinically indicated. Even if that 4-hour CT scan is normal, if there are any further risk factors present, such as a significant mechanism of injury, extensive head wound or bruising, an INR above 3, or lives alone with poor social support, then those patients should be observed for up to 24 hours and re-scan immediately if the patient deteriorates or becomes symptomatic. If the patient doesn't have any of those high-risk features, then they can be considered for discharge with verbal and written head injury advice after that 4-hour after that 4-hour CT scan. Post head injury symptoms are not an uncommon phenomena, and patients that have sustained a head injury may well present in the days to weeks after the initial head injury, complaining of a complex of symptoms that the cause of is not very well understood. But there's a definite cohort of patients that experience these symptoms, whereby they complain of feeling tired and lethargic, suffering from headaches, and also have some cognitive effects, especially memory disturbance, and also suffer from behavioural change and sleep disturbance. It's very important in these group of patients that are return that whether the clinical features they're presenting with could be due to intracranial pathology, and whether they require either initial or further CT scan imaging. And it's worth discussing them with a senior member of the medical staff. However, the majority of patients do not have a clearly defined intracranial lesion on CT, and they need to have advice that these symptoms are the symptom complex is relatively common in patients that have sustained a head injury, a reassurance that in the majority of patients the symptom complex settles in the weeks after a head injury, and they should be directed to obtain follow-up from their GPs. A very small number of these patients can have disabling and severe post-head injury symptoms that can prevent them from working or significantly affect their functioning in life, and those patients do sometimes require referral and input from a neuropsychiatrist, but that's certainly not the routine management of these patients. The majority can be managed by the general practitioners, and over the 2, 3, 4 weeks after the head injury, these symptoms will gradually settle. In the last part of this tutorial, we're just going to talk briefly about some of the intracranial pathologies that we might detect. The first of these is an extradural hemorrhage, which you will remember is most likely an arterial bleed, most commonly from the middle meningeal artery. And we know this is an extradural hemorrhage because it's a convex or lentiform type of hemorrhage pattern, whereby the hemorrhage is bordered by the dura. This is an arterial bleed and normally expands relatively rapidly. It's a neurosurgical emergency and needs to be discussed with the neurosurgical registrar as soon as possible. These patients will most commonly be transferred as an emergency to the neurosurgical centre, and will have a procedure to evacuate this clot. The most commonly performed surgical procedure is a craniectomy, whereby a plate of the skull is removed so that the hematoma may be evacuated. Another type of bleed is the subdural hemorrhage, which is normally a venous type of bleed. A subdural can be acute, so it can occur and form rapidly after a head injury, or a slower bleed can be a chronic bleed, or you can have a type of bleed where you have a chronic bleed but then has an acute extension. You can tell the age of a subdural hemorrhage by the colour of the blood that forms that subdural. So fresh acute bleeding is white on a CT scan, and it becomes progressively darker as the blood ages, until old blood appears black on a CT, and an acute on chronic subdural, where the age of the bleed differs, can have dark patches within the blood with white patches where the acute bleed has occurred. Subdurals can accumulate at varying speeds. They can have quite rapid bleeding and accumulate quite quickly, but they can also be very slow. And you do sometimes see patients who sustain subdural hemorrhages that are sent home initially with no clinical features at all, and then they present 4 or 5 days later with localizing neurological signs once that subdural has extended. The third type of intracranial bleed that we see after trauma is a traumatic subarachnoid hemorrhage. And you can see on this CT head scan that there is acute blood throughout the subarachnoid space. And on this scan you can see the ambient cistern where the circle of Willis sits is just filled with acute bleeding. Learning to interpret a CT head scan is a valuable tool for doctors working in the emergency department. It's something that with a little bit of experience can be quite straightforward to be able to see that the major types of bleeding. It's outside the remit of this tutorial to go through exactly how you should interpret a CT head scan. But a mnemonic that I think can be useful is the mnemonic blood can be very bad, and the blood stands for blood, so you should look for blood first. And then the C stands for cisterns, so then you look at the cisterns to make sure that they're open and they look to have an appropriate size and shape. Then to look at the brain to make sure that the brain appears to have a normal anatomical structure. To look for the ventricles. For the ventricle size, are they large, as they might be in hydrocephalus, or is raised intracranial pressure causing compression of the ventricles and effacement? And then look at the bones. So, is there evidence of a fracture of the bones of the skull? For anyone that's interested into reading a little bit more about this, there's an organisation called Fern, and I've put the link at the bottom, and they have put together a tutorial for both medical students and junior doctors to go through the basics of CT head interpretation. And when I was a registrar, I learnt my initial CT head interpretation from that tutorial, and I think it's quite a useful thing to have a look at. So, what are we aiming to do in the serious head injury? What are the key problems? Well, the key problems in a serious head injury is that you have an area of brain tissue that will be irreversibly damaged by the trauma, and there's not very much that we can do about reversing that injury, unfortunately. But around the area of primary traumatic injury, there will be an area of brain which will be imminently irreversibly damaged, but we have a period of time by which we can, with appropriate management, we can try and limit that injury. And that area surrounding the primary injury is potentially reversible. So how do we prevent that secondary brain area of that area of brain tissue? Well, it's about maintaining perfusion and oxygenation of that area of brain, and providing appropriate neurosurgical intervention to limit intracranial pressure. It's important to have an appreciation of a couple of pathophysiological principles, namely the first one being that of cerebral perfusion pressure. Now, cerebral perfusion pressure is your mean arterial pressure minus your intracranial pressure. So as your intracranial pressure rises after your head injury, if your mean arterial pressure stays constant, then your cerebral perfusion pressure goes down and the brain can become relatively ischemic. So we need to maintain mean arterial pressure and limit intracranial pressure, both by the positioning of the patient, some interventions that we will talk about in a second, and definitive neurosurgical intervention. It's important to realise that the brain, the intracranial vault is a closed cavity, and there's something called the Monroe-Kelly doctrine that applies to the principle of raised intracranial pressure, and that's that there are some spaces, both the ventricles and the venous sinuses, which can be compressed as the intracranial pressure rises. And you can see on the graph that I've put on this slide that rise in intracranial pressure is initially quite slow and steady, but once you reach a critical increase in volume, then all of those potential spaces have been compressed, and then you get a very rapid and devastating rise in intracranial pressure. So that's why patients can initially compensate and look like they're okay, and then suddenly deteriorate very rapidly. The clinical evidence that you see of rising intracranial pressure in this circumstance is third nerve compression and dilatation of one of the pupils, and that occurs as the intracranial pressure rises, the third cranial nerve is nipped against the tentorium and malfunctions, and so the pupil on that side dilates. If no intervention is taken at that point, then as pressure rises, the cerebellar tonsils are forced through the base of the skull into the foramen magnum, and that then puts pressure on the brainstem. The patient will sustain critical brain injury and normally sustains cardiorespiratory arrest, which is the mechanism of death in severe rises in intracranial pressure. So what can we do in the emergency department to try and counter this pathophysiology? Well, it's important to involve a senior doctor, a consultant or registrar early, and it's important to have that discussion with the neurosurgeons as quickly as possible. We want to control the patient's partial pressure of carbon dioxide, because carbon dioxide is a potent vasodilator. So if the PCO2 rises, this causes cerebral vasodilatation and further rises intracranial pressure. So we'll often intubate the patient and control their ventilation and aim to maintain the PCO2 within the normal limits of 4.6 to 6 kilopascals. Nursing the patient 30 degrees head up is thought to give the optimal balance between perfusing the brain and maintaining the mean arterial pressure, but also reducing the intracranial pressure slightly. And it's thought that this 30-degree angle is the most beneficial in terms of the ratio between mean arterial pressure and ICP. So optimizing that critical cerebral perfusion pressure. We need to maintain the arterial pressure, and we can do that with fluid or blood products, and considering use of inotropic agents such as metaraminol. But most patients, especially if it's an isolated head injury, will have a raised mean arterial pressure anyway. But if a patient has something else going on, such as bleeding elsewhere, then it's important to maintain that mean arterial pressure. If the patient has clear evidence of raised intracranial pressure, either clinically or on their CT imaging, then considering hypertonic saline can be a measure that we can take that temporarily reduces intracranial pressure and buys us enough time to get to a neurosurgical centre for definitive management. It's really important to appreciate that seriously head-injured patients require time-dependent management. The clock is ticking, and it's really important that we institute appropriate management in the emergency department, but also make arrangements to discuss and to transfer to a neurosurgical centre when it's clinically indicated. So I really hope that this tutorial has been useful to you in introducing some of the basic principles of both head injury assessment and management, has introduced some of the clinical decision-making tools that we can use to make appropriate decisions for our patients. If you have any questions that you would like to ask or discuss with me, then please email me. I'm more than happy to do my best to answer your questions. Or if you have any comments about this tutorial, you think that any information is inaccurate, or you'd like to just let me know about that, then please email me again at this address. Okay, well, I hope you have all the success in assessing head injury patients, and I hope to talk to you about this more on the shop floor.